Yeah, you can either use the QR code or you can type in Slido with the number on the screen. It'll be just great to find out what our audience want to hear from us, and then we'll try our best to source any of the speakers. If you actually want to come and present on this platform, you're welcome to do so, and you can leave the message on the Slido as well. Yeah, we can see a couple of suggestions coming through already, so thank you for those who've inputted. Are we just going to wait for maybe 30 more seconds before we start? Okay, so we'll make a start. So welcome to this month's ePrescribing Masterclass. I'm Amna Patel and this is Ho-Yan. We're both Chief Pharmaceutical Officers Clinical Fellows this year, and this month's session we've got 3 speakers. Just a bit about the monthly webinars. This is where NHS organisations share their experiences of digital transformation to help support other trusts and also share good practice and lessons learned from their adoption processes. Could just go over the housekeeping. So in the right-hand side, you see a toolbar with the questions, and if you can put any questions that you have for our presenters in that box, they'll either get answered today, and if we don't have time, they'll be answered later on and shared on the Futures platform. So you'll see on the agenda today, we've got 3 speakers. There's Paul, who's presenting an update of the NHS DM&D forms at the BMP level. We've got Ben and Leah, who will be presenting on the risk of incorrect penicillamine allergy recording instead of intended penicillin drug group. And we'll have Tamina, who will be presenting on the Pharmacy First programme. So I'll just move on to our first speaker today. So we've got Paul Wright, who's the pharmacist and principal technology specialist at NHS England, and he'll now provide an update for one of the terminology enhancements being made as part of the UK Medicines Terminology Futures project. I don't think Paul's camera's working today, but you should be able to hear him. So I'll hand over to you, Paul.
Thank you, Amna. Can you hear me okay?
Yes.
Thank you. Apologies, yes, with the camera situation. So yeah, good afternoon, everyone. Nice to meet you all. Firstly, thank you to Amna and Ho-Yan for having me on today's session. So I'm Paul Wright. I'm a pharmacist by background. I'm currently working as a terminologist within pharmacy terminology in NHS England. And I've just asked for a couple of minutes at the start of today's session to provide an update for one of the enhancements that we're making to our terminology products, which are the NHS Dictionary of Medicines and Devices, the DM&D more commonly known as, and the SNOMEDS UK drug extension. And my update is particularly in relation to one of the enhancements that we're making, and it's around an update to drug forms at the VMP level of DM&D. And this is one of a number of enhancements we're making, and I've popped a link into the chat to give you more information around this particular enhancement that we're doing, but it will also take you to information around other enhancements that we're doing, why we're doing this, the overall project of work, the timeframes for the work, etc. So I have delivered an update about this particular enhancement before on the masterclass back in October. That was in relation to the phase 1 changes that we were making. And now today is an update around the phase 2 changes. So there are 2 phases in total, and this is the second phase that we're making. We've agreed the time frames of changes for phase 2 back in January, and as this is the first masterclass of the year, this was the first opportunity for me to provide an update to you all around the phase 2 changes. If I could go on to the next slide, please. Thank you very much. So I have got a hyperlink at the top of the slide, which gives a link to all the information around this particular enhancement, and it goes into the detail of why we're making this particular change, what exactly is changing in the terminology and what people will see, and the timeframes for the work, and also more detail as to the rules around some of the changes that we're making for this work. But I have also put that link in the chat as well if people are obviously unable to get to it on the screen. So just to recap around this particular change, so we're updating drug forms at VMP level in the DM+D. This doesn't impact the VMP description, but a particular attribute within at the VMP level. And we're doing this to align more closely with what we call EDQM terms, which are used at international level. And that's why we're doing the work. But what it will do is provide more granular information around drug forms. So for example, in the phase 1 changes, you can see where we've got capsule and tablet, those drug forms will all remain in DM&D, but we will have created some new drug forms. So for capsule and tablet, we created oral capsule or oral tablet, and vaginal capsule and vaginal tablet. And that more granular information now sits in DM&D. So just to recap, we undertook a sample batch, is what we called it, of ointment back in August. And what it allowed us to do was just to create a small number of changes, but to VMPs where there is usage. So we can just go through that process and then people can see what potential changes there may be in their systems, in their IT systems, or to end users before we went ahead and made the larger changes. And the larger changes of the phase 1 and phase 2 we're making over separate times. So we have completed the phase 1 changes, and they were done in November 23, and the 7 forms, as you can see, are on the screen. And so now we're moving on to the phase 2 changes. The difference between the phase 1 and the phase 2 is the phase 1 all took place in a single week in the DM&D data in November, and the phase 2 changes are going to take place over a number of weeks. And then the 6 forms that are going to be changed as part of phase 2 are at the bottom. So implant, implantation, suspension, etc. So if I could just move on to the next slide, please. So all this information I said is on our website, but I just wanted to highlight this to people. So when we create new drug forms for say implant or implantation suspension, we release those out into the DM&D data on Monday the 15th of January. So that's already happened. But what doesn't happen is we don't assign those new forms to any VMPs until the dates within that table. So we're making these phase 2 changes over a number of weeks, as I said. So the first happened on Monday the 29th of January, and there were 4 form changes which we made changes to. So that's now live in DM&D data. In terms of the numbers, there were around 45 VMPs that were changed as a result of that work. And so now we've got Monday the 12th of February, which is next week, and then Monday the 19th of February for the next lot of changes, which are to liquid and powder. And I can report there are going to be around 320 odd, 325 liquids that are being reviewed as part of this work. Around 52 remain unchanged, and around 265 are going to be updated to one of the new forms. Confirmation of all the changes that we're making will be in what we call our weekly release notes for DM&D, and there's a link to access that, and that is on the NHS BSA website. So if you just googled NHS BSA DM+D, it'll take you onto a page, and the weekly release notes are there, but it's also on this slide as well. And we've also got information advising how technical queries can be written to identify these VMP changes, should people want to do that, and that's available on that website and at the bottom. And that also gives you information about how you can query them, both in TRUD, which is the traditional method that we release DM&D files through in the XML files, or through the NHS England terminology server, which is a new server which DM&D data is available from. And just the last slide, please. So just to provide an update, and this information again all on our website. So for implant, so you can see the current description of implant and then the code, the SNOMED CT identifier next to it. And what we've done is we've created new forms which which marry to EDQM forms. And so what we'll be doing is we've reviewed all the VMPs with implant as a form, and either it retains a form of implant where they exist in the rules, or we'll be given one of these new ones. And we've got the list for all of them. This is just one of the examples, but there are some rules, as I said, where some of these forms won't be updated. For example, where a VMP has no route information, or where we currently have it as route not applicable, or where there are VMPs marked as invalid, they retain the existing drug form. So the website at the bottom there gives an overview of the whole of the project and all of the enhancements and timeframes. And we have a centralized mailbox at the bottom as well, which goes through to our project team. So if anyone ever has any questions about this work, please feel free to contact us. And we've also, we circulate this information around a number of routes, and have recently done that as well out through our perm team to NHS trusts as well. So if people have seen those emails, this work relates to that. That was everything I had. Amna and Herian, so I've finished mine, and happy to take any questions if anyone has any, or please do send things through to our centralized mailbox at the bottom if you do think of any in the future.
Thank you, Paul. That was really useful update for everyone, and thanks for sharing the links in the chat box. Does anyone have any questions? If you do, please put them in the chat box, and I think Paul will be staying on, so you can answer them whilst we're still here. Okay, I'm going to just move on to our next presenter today, and we've got Ben Logan, who is the lead EPMA pharmacist at Liverpool University Hospitals Foundation Trust, and Leah Baker, the lead medicines safety pharmacist and medicine safety officer, and they're here to present today their presentation on the risk of incorrect penicillin allergy recording instead of the intended penicillin drug group. So I'll just hand over to Ben and Leah.
Yeah, thank you very much. So I'm Ben, I'm the lead EPMA pharmacist. I'm just going to go over a brief overview of a problem we found in our system, really. It's quite specific to our system, but we'll touch on a lot of the safety elements and our response to it, and how that applies to wider systems as well. So if could have next slide, please. So just to give a bit of background to our trust, really, and why this has been quite a significant issue for us. We were originally two trusts, which was Aintree and the Royal, which launched our original EPMA system way back in 2009, which was JAC. These were both then upgraded in 2014, and we stayed on these right up until July 2023. So in 2019, the trust was actually merged. So this was one of the reasons why that upgrade took so long, and we're on that system for such a long time. We merged in 2019, then there's a big operation to sort of get those two systems, which were very different. Although they were the same system, they were very different clinically, and there were a lot of decisions that needed to be made. And due to that fact, we had to start with an entirely new drug build, an entirely new patient build, so we lost all of our allergy information because it was just too difficult to transfer all that across. And that's why we're now in the position that we are in July 2023. So next slide, please. So we're actually, one of the problems and one of the things I wanted to touch on is that because we went live so early in 2009 and we're on that system for so long, it was really ingrained within our trust. People were so used to that system that although when we upgraded our system, it went from a Windows client-based application to a web-based. A lot of the underlying functionality was exactly the same, but people were so used to what they've been using for a best part of a decade that it was really quite a hard transition for people to take. And I think expectations were possibly a bit different because we weren't merged. Although it's a big change, we weren't going from paper to electronic. We were going from electronic to electronic. So people want, if not the exact same features, they want enhanced features as well, especially when you're viewed to be on quite an old system. So that was also quite hard to manage in terms of expectations. And I suppose an example if we're talking about allergies is you go from a paper chart with no allergy decision support to have an electronic system where you're expected to pick up all allergies, all interactions with drugs, and then if that's suddenly not as good as it was in the old system, it really presented a lot of problems for us. Next slide, please. So how does allergy recording work? I'll just give a bit of background on that. So allergy recording is mandated in our system. The library comes from First Data Bank, and we're not able to modify that. It allows users to add individual drug allergens or drug allergen groups. When you've added an allergy, it provides decision support, so we can set that up to completely block prescribing of allergens, or it can just provide you with an alert that you can override, say, I still want to prescribe this drug, and I accept the risk. I've already mentioned the allergy data was not carried across into the new system, so we started with completely fresh patient records. And another issue is there's no minimum character length for search with the allergy recording. Next slide, please. So I've put an example here of the change, and I alluded to the fact that we changed from a Windows-based system to a web-based system. This changed a lot of our the look and feel of the system. So on the left, you can see we just had a big drop-down list for allergies, which is probably quite clunky, but it served a purpose. You can see the penicillamine, which is the issue that we're talking about today, is next to penicillins, but it's still quite easily identifiable. You would think that most users would recognize penicillins as the allergy that they want to add. Whereas on the right, the system defaults to searching via a drug allergen. So if you search in penicillin, or up to 8 characters actually, would bring up penicillamine instead of penicillins. And to actually find the penicillin drug class, you have to click drug allergen group, which is the bottom screenshot on the right. So you can see where this issue has cropped up for us. Next slide, please. So just to give a bit of background on penicillin for those who might not know, it's not penicillin, it's a DMARD drug, and it's actually quite very rarely used in the country. So just put a bit of a graph there from open prescribing data just to show that we're looking at about 500 boxes nationally, so very rarely used. Next slide, please.
Okay, so when you think about the process of adding an allergy for a prescriber, we've already heard that it's actually mandatory for a prescriber to add an allergy before they can then do their prescribing tasks within our system. Increasingly in an acute trust organisation like ours, of which we've got 2 large A&E departments across different sites, the prescriber is entering the allergies to quite rapidly reach the process of prescribing. That may well be for the acutely unwell patient who you need to rapidly prescribe some antibiotics for. So even though the focus of the task at hand should be the correct entry of the allergies followed by the correct entry of the allergic reaction and or sensitivity, that might not take the time and care from a prescriber perspective that is needed. So there is some behavioural and priority elements that influence the risk of this allergy as well. But if we do pause for a moment and have a check of whether in fact we are all geniuses by the fact that we can quite quickly and rapidly read what the middle image on the top of our slide shows, we may actually see what we want to see or what we believe to actually be there. And Ben's already referred to the fact that there is 8 characters, which is actually deemed quite a high number of characters that you would have to bypass or enter more of before you got to penicillamine. So if we type penicillin and we're presented with a partial correct response, again, just to reiterate, we may in fact believe that is what we intended to enter and quite rapidly move on to entering the type of allergic reaction. Within our current system, the mitigation in terms of trying to reduce this error type is the green banner that you can see highlighted on the screen. It highlights the fact that there are different methods of adding either a drug allergen or a drug group allergen, followed by an additional signposting comment if the user has typed in the start of the words of penicillin or penicillamine. That green banner in fact fades over 5 seconds, so it is initially green. It will quite rapidly go to a white banner and potentially at risk of not being seen by a user. And if we just think quickly from those of us who may well be involved in human factor education training previously, from an error prevention perspective, that's not really an engineering out of the system, the issue and the risk that we have. It's a mitigation step to put an extra barrier in place. If I can have next slide, please. And just to reinforce from the perspective of any healthcare professional, but more commonly than not the prescriber of confirming an allergy, primary care records will often look like the top box that you can see there on the slide. So the reference to penicillin allergies is often via the drug group rather than the specific drug. And then when questioned, patients will often reinforce that. So to ask a patient a question of are they allergic to any medicines, they will often pretend, if they have got a penicillin allergy or sensitivity, they will say yes, penicillin. They won't most commonly refer to the particular drug of amoxicillin, phenoxymethyl penicillin. And then we should be qualifying quite quickly what the type of reaction is. And for those patients who maybe do unfortunately have an anaphylaxis or an angioedema reaction, quite quickly that then is the alarm bells to a prescriber or the healthcare professional that is entering the allergy, and their focus may well shift to that. If I can have the next slide, please. That then leaves us with a risk organisationally at the moment that patients may be mislabelled as having a penicillamine allergy when in fact they may have a true anaphylaxis or angioedema reaction to penicillin. By default then, if penicillamine has been incorrectly selected, the decision support that Ben's alluded to, whereby we have built into our system, you are not able to bypass if that type of allergy reaction is recorded, means a risk of a patient being able to be prescribed any of the penicillins without a system warning in place, and the ultimate risk of anaphylaxis, angioedema, which most of us would recognise can actually be a fatal reaction. There is also an additional risk of miscommunication out of the system at the point of discharge across the interface to primary care, that if that incorrect allergy isn't identified, that then a penicillamine allergy could in fact be added to a system, and we can potentially get into a cycle of the incorrect allergy being added and recorded on multiple occasions across the system. And again, just to allude to the fact of how significant the penicillin anaphylaxis reaction is for those people who are truly anaphylactic to penicillin, accounting for in some references of up to 20% of drug-related anaphylaxis deaths across Europe. And we've got a reference there. So this risk does sit on our organisational risk register. Initially, quite a high risk score of 12, and has got some reduction based on some of the mitigation, which we will now describe. If we can move to the next slide, please.
Yes, this is a chart I put in just to highlight the issue that we've had. When I said we went live about July last year, you see that over time penicillamine allergies up until that date in July were minimal in the old system. And when I showed that interface before where you selected from the drop down list, that shows that was simple enough to alleviate the issue. When we've gone live, this is grouped by month. You can see we're just getting way into 60 plus each month. That's probably a bit worse for us because, as I said, we didn't have any all our patient records were blank when we first went live. So we would expect that to die down over time because you're not forced to add an allergy every time the patient comes in. If we could have next slide, please. Should just talk about our mitigations. So we had knowledge of this issue mostly because I had worked at another trust where it was identified. When we were doing our upgrade process, there wasn't really a point where we were told about this risk. It was originally on the company's hazard log, but that was taken off due to the mitigation that they put in with the banner that Leah was talking about. So other than that, we didn't really have any visibility of the scale of this issue. And I think it can possibly be quite hard to notice for some people. I don't know, if you're a pharmacist going up to the ward and you review a patient's allergy history, you might notice the odd penicillamine, but that collective effort to notice that there's maybe a wide scale problems not immediately obvious, I don't think. So it's almost spread by a word of mouth, or that's been our experience at least anyway. So one of our first mitigations was to document it on our clinical safety hazard log. And we initially scored that as likelihood of medium. This is because we just didn't have the data. So the graph before shows that it's very likely to happen. It's happening all the time. We then scheduled a weekday report, so that was screened by the EPMA team. We set that up to send automated email triggers to the prescriber if they had made a mistake. We also included it in all the Go Live training, so without that knowledge, without me having seen this at another site, that probably wouldn't have gone into the Go Live training. We wouldn't have been able to send that to all our new users. that training was, we had something like 9,000 users to send training to, so it was all we didn't mandate training, it wasn't linked to ESR or anything like that, it was self-directed, there was no assessment, so that possibly could have been a lot more effective if we'd have had the time and resource. And we also sent several communications to staff. So this report is a live report. You can see a lot of questions coming in about and comments on other people's mitigations, which are very similar, which is interesting. Next slide, please. So once we got a bit of an idea of how big the problem was, we added it to the risk register, which Leah showed on a previous slide. It was also acknowledged at a board level. We have an internal web portal that we use and the pharmacists use to prioritize all our work and see various safety warnings, and that was added. It was added to that, so pharmacist has to go through this page in the web portal to see there's a penicillamine allergy recorded. You might want to have a look at this patient. That's if it's not caught by the EPMA team. But first, we sent several more communications to prescribers. We put it in a safety newsletter. It was included in face-to-face junior doctor teaching, and we also introduced weekend reporting tools as well, and that's done by the clinical pharmacy team, which they have to acknowledge at a weekend. And we've also put in an enhancement request with the supplier. So I think there's a lot of mitigations here for what seems like a really simple issue, and I can see everyone in the chat is saying that they've done very similar things from Crystal report. So it just goes to show how a simple issue which could possibly be fixed is draining a lot of resource from a lot of different sites. So next slide, please. So one thing we decided to do to get a bit of a scope of the issue, and sorry if this came across everyone's desks who's on the call, but we sent a freedom of information request to a lot of the trusts in England just to get an idea of how many problems everyone was having. Are people seeing the same issues that we're seeing? So we asked mostly how many penicillamine allergies have you had recorded in the last 12 months? How many penicillin allergies have you had recorded? So the light blue bar is penicillin allergies, the darker one is penicillamine, and then we asked what supplier everyone was on. So I've not put the names of the suppliers on, but you can see there are particular issues with some suppliers. It's non-existent with some suppliers, but some do have this issue. So next slide, please. I should have commented on actually with that one. The FOI has been shared with NHS England as well, who've asked for a copy of that.
Okay, so lots of us will probably also know that back in January 2023, one of the MHRA drug safety updates, we were asked to be vigilant for incidents involving software, which may then include electronic prescribing systems, and to record them via the yellow card system, as well as potentially any local incident reporting system. We did then, therefore, in fact, consider this at the point where we were getting the frequent penicillamine incorrect records for yellow card reporting, and have submitted those for the cases where the penicillamine was the incorrect recorded allergen and the reaction for the patient was in fact anaphylaxis to penicillin, and over time have probably submitted in approximate of 20 yellow cards. All of our incidents have been detected, so are no harm events locally, and what we don't know or haven't got visibility of, and hopefully we will see going forward in the future, is what the impact of reporting within yellow card systems will be. Next slide, please. Just in terms of summing up, where are we now? We aren't actively following up potentially any penicillamine allergies which may have slipped through the net, so our rapid turnover of patients whereby they may have been seen in the AED department, which is something that we will have to consider. So lots of the penicillamine incorrect reporting are being picked up. The reports are being run weekdays and weekends now, so it should be minimal, but something to consider. Training and feedback is ongoing. Identification via our reports and correction 7 days of the week is in place, and to view whether a further future upgrade would mitigate entirely would be the optimal position. We've described there for some just context what the SOP looks like for the APMA and pharmacy team who are undertaking the view of the reports, and the message which we will add to our system if on rare occasion it's not been possible to actually confirm what the true allergy is. If I can have next slide, please. Ben has already alluded to the fact that we have shared the data from the Freedom of Information request and our experience at Luft with the NHS England patient safety team. They actually already had an investigation underway on the basis of sharing of concern from another organisation in the UK, and they've kindly asked us to share their details as well, and they will be presenting at a future webinar. And just to finish, myself and Ben are absolutely happy to be contacted if we can't respond to the questions today, or anybody would like to link in the future. And if you just jump to the next slide, it is just the opportunity for any questions to be posed to us. And just as a reminder, there are a couple additional slides which we will just need to skip over, ready for the next speaker. So thank you very much for listening. Thank you.
Thank you, Ben. Thank you, Lee, for your excellent presentation. I've jotted a couple of things down. I think it's good to hear that sharing of knowledge happened within a community, and it happened before implementation. Obviously, platforms like the ePrescribing Masterclass, we are here to facilitate dissemination of good practices. From the comments that we've had in the chat, most of them has been answered during your presentation, and there was a lot of comments around what other trusts do to mitigate, and it's kind of what you guys already are doing. I think it's been helpful to reflect on some of the risks of health IT system that can bring, and that both suppliers and users have a responsibility around patient safety. And there's obviously a call to action as well, which is also mentioned in the chat, to be vigilant while using technology and to use the yellow card reporting scheme to highlight any patient safety issues. So I think I'm going to leave that for now, because I'm going to move on to our next presenter. Before I do that, thank everybody for joining. Thank everybody for putting questions in and interacting with us. I've seen a couple of familiar names in the chat and in the audience, so it's good to see. Let me have a look. I don't know if Tamina have joined us. Hello, Tamina.
Hi, yes, I'm on.
Yeah, okay. Tamina, unfortunately, her camera is not working. So let me just do a quick intro. Tamina is here to talk to us about Pharmacy First. Tamina is a national clinical lead for community pharmacy in the digital primary care team within the Transformation Directorate at NHS England. Like many of us on the call today, she started her career in secondary care, and then she's gone on to work into a portfolio career across urgent and emergency care, primary care, and academia. In 2017, she became a Chief Pharmaceutical Clinical Fellow and was offered a placement at NHS Digital. And I think that's where her love or passion for digital really flourished. She worked alongside with senior pharmacy leaders and led on several digital transformation projects. After her fellowship year, she returned to NHS Digital and became the clinical lead in digital medicine. More recently, she's been leading on the delivery of the community pharmacy digital priorities as part of the primary care access recovery plan, including the launch of Pharmacy First service. And today she's here to speak about the service and the digital pathways that needed to emerge, the infrastructure that needs to be in place for this national program to take place. So Tamina, I'm going to hand over to you.
Thank you so much for that lovely introduction. Hopefully I can follow with the presentation. So thanks again for kind of asking me to join. I realise that a lot of you on the call today will have probably had Pharmacy First sort of kind of pushed into your face via lots of the news outlets and kind of media coverage out there this week and last. What I'm going to try and focus on to try and keep the kind of presentation relevant to this group is the digital aspects. So I will very quickly kind of cover a little bit of the background of the service, but then I'll move on to hopefully the exciting bit, which is what I've kind of been primarily leading on, which is the sort of digital elements, some of which are already live and some of which are to come. So yeah, next slide, please. So yeah, as I said, I'll be kind of covering kind of the background of where the sort of service emerged, a little bit about what the service is about, what the sort of digital ask was of NHS England to support the service, and then I will do kind of a more focused sort of couple of slides on the GP Connect update record functionality, and then there will be opportunity for some questions at the end as well. Next slide, please. So the Pharmacy First service was really kind of all kicked off after the Primary Care Access Recovery Plan was published back in May. And there were three kind of key commitments in there towards community pharmacy. One was to launch the Pharmacy First service, which would enable the supply of prescription-only medicines via PGD for 7 common conditions. And then the other two sort of commitments in there were to increase the kind of uptake and rollout of the existing blood pressure check service in community pharmacy and the contraception service. And the third bit, which is sort of where kind of I come in primarily, is really around improving and building on the existing digital infrastructure and the kind of interoperability between GP systems and community pharmacy IT systems. So quite a big ask and a challenge, hopefully, that we've kind of risen to as a pharmacy sector and in the digital space as well. Next slide, please. So very quickly, what is the Pharmacy First service? So it builds on really the existing community pharmacist consultation service, or CPCS as it's commonly known, which kind of on the right hand side, as you can see, were previously commissioned by NHS England with two kind of sub-services. One was referrals from 111, urgent and emergency care, and GPs for sort of common minor illness conditions, and the other sub-service was referrals from 111 for kind of emergency supply of repeat or prescribed medication. So those two parts of the service will continue, but will now be under the kind of banner of Pharmacy First. And the new element is the bit on the left, which is referred to as the kind of 7 clinical pathways. And they are these 7 kind of conditions that pharmacies will now be able to issue prescription only kind of medication for via PGD under certain circumstances. So there are some very kind of strict, as you would expect, inclusion-exclusion criteria and pathways that are laid out with kind of appropriate referral routes and kind of advice where antibiotics or antivirals might not be indicated, but the pharmacy may be able to offer the patient or support them via other means. So that's kind of the new part of the service, but the whole thing is sort of being kind of branded under the umbrella term of Pharmacy First since the 31st of January. So we're about a week into the service, and up to kind of 10,500 pharmacies, or almost 10,500 pharmacies, have now opted into the service, which is a really, really positive outcome. So there should be kind of good coverage for patients across the country. Most pharmacies are now providing the service, and with a good proportion of 100-hour pharmacies also offering the service. And obviously the whole kind of purpose of the service is to provide patients with better access into primary care services, and also to relieve some of the burden that we're seeing in general practice and urgent emergency care services as well. And I guess kind of from a profession perspective, it's really investing in the community pharmacy sector and also really kind of paving the way for community pharmacists and community pharmacy teams to offer more clinical facing services, and really kind of preparing them for prescribing in the future, as well as sort of using and maximising existing kind of skills and expertise. Next slide, please. So in terms of the digital ask, there were quite a few work streams that we kind of wanted to launch really as part of the Pharmacy First service. Some of these elements are directly to support Pharmacy First, and some of these things are kind of more general in terms of access to records, and updating GP records is more of a overarching kind of need in community pharmacy for many services. So whilst we have kind of focused on launching the initial elements of these things for Pharmacy First, the ambition is that these things will also be kind of extended to future pharmacy services and existing pharmacy services as well. So the first element that we needed to tackle really was the channel shifting of patients. So how do we make sure that patients, professionals, pharmacies are kind of clear on which pharmacies are offering the service and kind of which patients should be going to the pharmacy instead of their GP or 111 or A&E, for example. So there were some significant changes made to the directory of services, Profile Manager, NHS.UK, 111 online and 111 telephony pathways as well. And all of these things kind of in combination means that pharmacies are basically kind of highlighted, for example, in Profile Manager as sort of sites that offer the service now, and therefore patients can see which pharmacies provide the service. They can be triaged via 111 telephony in kind of appropriate circumstances, and via 111 online via the NHS app, for example. And then the sort of DOS changes means that referrals can be directed to pharmacies as well via that route. The second kind of part of the launch was to ensure that pharmacies had appropriate, robust systems to be able to record consultation details. There are some established systems that community pharmacies use already to support existing services, and these suppliers developed new consultation records to capture the data that we want as part of the Pharmacy First service. So not only is some of that data for the consultation kind of record in terms of what's needed from a clinical perspective, but as you can imagine, there's a lot of data and reporting that we want out of the service, particularly to kind of monitor things like antimicrobial resistance, because there is a risk that patients may be able to access antibiotics more easily, and that's something that we need to keep an eye on. The other elements, I'll come to remuneration first, which is just on the bottom kind of left there. The BSA developed an API that the community pharmacy IT systems developed an integration with, and that was to allow that data to flow to the BSA so that NHS England are getting kind of a good sort of surveillance and overview of what's happening out there in practice, but also to support remuneration processes for the pharmacy itself. And then the three other elements are kind of where I would say is the exciting bit. So I'm going to kind of dive into the update record element in a minute. The other two bits that are going to come kind of post-launch is access to the patient's GP record, and that is via the GP Connect Access Record API. And what that will allow is greater access to the patient's GP health record beyond what community pharmacies have access to now. So summary care record, which I'm sure a lot of you will be more than familiar with, has been established in the community pharmacy sector for a number of years now and works really well. However, there are limitations in that it gives you a snapshot of medications and allergies, 12 months of medicines, and it is dependent on an update from the GP kind of end. So sometimes the information may not be kind of as up to date as you need it to be. As well as that, you have to come out of your community pharmacy IT system, log into Spine, and sort of access it outside of your system. So there's additional kind of steps there. It's not a great user flow. And to support some of these more kind of clinically focused services, some of the information that pharmacists need to support clinical decision making isn't available through SCR. So in order to kind of provide a greater picture of the patient's record so that clinical decision making is safe, but also that it unlocks the potential for pharmacies being able to deliver more, we've asked the community pharmacy IT suppliers to develop the GP Connect Access Record API. And what that will allow pharmacists to do, and pharmacy technicians, is to access the patient record, obviously with the patient's consent, and the sections of the record that will be visible are medications, any observations that are recorded in the practice, so for example, blood pressure readings, investigations, so test results, you know, lots of kind of useful information there to support medicines management. You'll also be able to see consultations, patients' problem list, immunizations, and collectively all of those things will obviously give the pharmacist and pharmacy technician kind of more information to make safer decisions about the patient's care. Some of that will be staggered in terms of delivery. So the focus initially will be the medication section, and then the other sections will follow thereafter. And the data will be structured so it will come in directly into the pharmacy IT system. So it won't be a kind of a read-only PDF or a read-only extract. Because it's via an API, it will be a live call to the GP record, and it will ingest the information into the pharmacy system so that it's kind of within the system as opposed to taking you outside to another like client or another login page. I don't have any screenshots to show you at this stage. This is very much still in development, but we are hoping that over the course of the next couple of months that this will be in a position to go live across those 4 pharmacy systems that we're working with. The next bit is the referrals element. So some of the pharmacy services, including Pharmacy First, is reliant on referrals from GPs as well as 111 and urgent emergency care. 111 referrals currently come in via ITK messaging, but GP referrals, there isn't a kind of a national solution for GP referrals. There are some bespoke solutions out there that practices are using, but they're not kind of ubiquitous across the country. And there are some differences in experience depending on what system the pharmacy has and what system the GP has. And therefore, we want to kind of standardize that. And the sort of national kind of solution for that is the Bookings and Referral Standard, or BARS as it's abbreviated to. It's a standard that essentially kind of lays out exactly what referral information should be in the referral and how that should be shared. And again, the 4 pharmacy systems that we're working with are developing to that standard. And again, it's something in the works that we hope to launch over the next few months as well. So in terms of the scale of change, the focus was on Pharmacy First service, but also the blood pressure check service and the contraception service. We're dealing with 10,500 pharmacies, 6,500 practices, and 6 IT systems across those sites. So it was a massive kind of undertaking, and that's why some of the functionality isn't quite ready for launch and will follow kind of soon after. And I'm sure that, you know, everybody on the call is very familiar with digital projects and how things sometimes don't quite go to plan. But it was decided that the service was safe to kind of launch, and some of this functionality will hopefully improve and enhance experience as we kind of roll it out, as I say, over the coming weeks, months. The 6 systems that we worked with, Sonar Informatics, EMIS Pharm Outcomes, Sedgden Pharmacy Services, Positive Solutions are the 4 pharmacy systems, and then TPP System 1 and EMIS Web are the 2 GP systems that we've been working with. So we've got almost 100% coverage of the pharmacy estate and around 99% coverage of the GP estate. So we've got 10 minutes. I'll try and whiz through these next few slides, so we've got a bit of opportunity for questions. So GP Connect update record is, sorry, next slide. I haven't been asking you to move on to the slides. Sorry about that. So in terms of GP Connect update record, this is another GP Connect product, a little bit like Access Record, but this allows you to send an update back to the GP system. The idea is that this is the method of communication for all external organisations with GP systems in the future. Pharmacy happens to be the first use case, and we are currently in first of type with this, so this is very soon to be rolled out into live. So next slide, please. So how it works is the pharmacy IT system collects the information as they would as part of their consultation. That is modelled against a standard that was developed by the Professional Records and Standards Body, the PRSB. So they kind of did an exercise a couple of years ago with lots of stakeholders to agree on an information model. So what should pharmacies be recording as part of these services, and what information should they be sharing with the GP, recognising that not all of it is necessarily relevant to the GP. So that was agreed, and the pharmacy IT systems have been modelled against that. The GP Connect update record specification then sort of describes to the IT suppliers of that information that's captured, how can that be mapped against FHIR profiles. So FHIR is a messaging standard used across the NHS, and it's the kind of standard messaging that's been used in the NHS to support interoperability. So that's the model we've gone with, and what that then allows is that message to be received by the GP IT system directly into their system as a coded, fully structured message. Next slide, please. So in reality, what does that mean? It means that messages, as I say, will appear in the GP system directly. So at the minute, the kind of as is that these messages go into the practice's generic mailbox via email and a PDF attachment, and it requires practice staff to copy that information, attach it to the right record and transcribe details into the record, which, as you can imagine, is a lot of administrative burden, but also there is risk there that things like medicines may not be transcribed correctly. So with this kind of functionality now, the messages will appear in the GP system generic workflow. The patients are PDS verified, so we know that we've got the right patient, we've got the right practice, and it's synced to the patient record at the point at which it's accepted into the system. So it won't require somebody at the practice to have to try and match it to the right record. The data is held provisionally against the patient record, and then a member of the practice team will need to review that data and file it. And at the point at which it's filed, it will then be ingested and will be available to view by others, for example, accessing the record. It will be available via summary care record or access record if you're looking at that. And there's no need for transcribing or recoding. Obviously, this is kind of the first iteration. So whilst the majority of the message is coded, there are some elements that are free text still that will hopefully be coded in future iterations. Next slide, please. So the benefits, I hope, are fairly kind of obvious in that comes into the workflow, so nothing's missed, nothing's sitting in the mailbox and requires administrative staff to manage a separate mailbox. There's no kind of attaching files or attaching PDFs. There's no manual coding, manual kind of transcribing. It's much safer because the information lands in the patient record straight away. So if the patient turned up the next day to the practice for another complaint or the same complaint, the practice would know that the patient's been to the pharmacy and they were supplied with some medication, or it could be that the pharmacy refused to supply medication because of whatever the reason was. So all of that is really helpful in kind of subsequent decision making by the practice. The information is clearly attributed to the pharmacy. So whilst it looks like somebody at the practice has entered it because it's a fully coded message, it does have a clear attribution to the pharmacy and the pharmacy user. So it's very clear it's an external kind of user that's issued the medication. Next slide, please. Just some screenshots I thought would be helpful to kind of demonstrate the functionality. So on the left-hand side, you can see this is what we call the workflow in the GP practice system. So all messages, letters, communications that come into the practice come into this generic workflow. And as you can see, just the highlighted top one, it says it's a GP Connect update record message received. And underneath it tells you that it's part of the community pharmacist consultation service. Obviously now the pharmacy first service. It does say send unrecognized there, but that will pull the pharmacy details through. This is just test data, so the pharmacy wasn't kind of registered in ODS. And then, as you can see on the right hand side, the details come through. Things like blood pressure observations are fully recorded, so will contribute to the practice QOF indicators. But also, if the patient was to access their own record via the NHS app, they'd be able to see that information as well. They'd be able to see trends in their blood pressure, and this reading would contribute to that trend. And then the second the third screenshot underneath shows you a medication entry. So that would be added to the medication list for that patient, and it can be reissued by the practice if they wanted to reissue it. So, for example, for the contraception service, the patient may be going to the pharmacy on the odd occasion, but they may also be getting medication from their practice the following month or a few months later. So the practice can actually reissue it using that entry that's gone in. Next slide, please. This slide just shows the exact same thing, but in the EMIS system. So it's very similar. I'll just leave it for a minute or so, just so you can see that again, just goes in the exact same way. Maybe not a minute. And then next slide, please. I think that's probably the final, yeah. I know I haven't left much time for questions. I'm happy to take things offline, but I'll hand over to Ho-Jan now. Thank you.
Thank you, Tamina. That was a really good presentation. I know you've been really busy in the midst of the launch and obviously the GP Connected. I think from reflection, apart from obviously the clinical benefits to the patient, for the community pharmacies now being able to see the records on the GP system will be quite transformative in terms of what they can deliver in the future. So not only for this 7 indication, but potentially more things that they can do in terms of clinical services. We're left with 3 minutes. I think from the questions, most of the things you have answered during your presentation. I'll just round up. I think you did say you were happy to answer any questions that were posted. So for anyone whose question hasn't been answered, you should be able to see them on the Future website within a week or so, where the presenters will put their answers to your questions. So on this slide now, if you haven't done so already, please scan the QR code on the slide. There's just some feedback we wanted from the audiences in terms of what you want to see on future iterations of the ePrescribing Masterclass, and also if either you or a member of your team would like to contribute to the webinars, you can leave your details there. Yeah, so certificates will be available and sent out towards the end of the week, and also recording of the webinar is viewable. Questions? Yeah. Anything else I've missed?
No, just the next masterclass, like it says, is on the 6th of March. So we'll be looking forward to seeing those of you that attend that session.
And I've really enjoyed hosting the webinar, so I hope you did too.
Yeah, no, it's great. So like we said, any of the questions that haven't been answered in the chat box will be put on the Futures platform, and you should get notification of that as well. So please do put any topics down in the questionnaire that we've put on screen.
And enjoy the rest of your day.